Welcome back everybody, David here with Med School Bootcamp. So in this next video, we're now going to talk about something called nephroblastoma. Sometimes it's also referred to as a Wilms tumor. And a Wilms tumor is the most common malignant kidney tumor in children, and it's something we rarely would see in adults. So we want to keep this in mind as we're building our differentials depending on the patient's age. Now, a Wilms tumor is composed of cells that play a vital role in kidney development, and these are called metanephric blastomal cells. Now, when we talk about the etiology here, it's important to keep in mind that it's often unknown. Sometimes children just get these tumors and we're unsure of what the actual cause is. However, there are a subset of cases where a child will get a Wilms tumor and we can actually contribute it to a genetic cause. And this is often due to a loss of function mutation on a tumor suppressor gene. The two most commonly known ones are WT1 or WT2. Now, just as a bit of a reminder, what's the difference between a tumor suppressor gene and an oncogene? Well, a tumor suppressor gene typically suppresses cancer at baseline. So if this is inhibited or if a loss of function occurs in the tumor suppressor gene, we're no longer able to suppress the tumor, and that's going to cause growth. So again, a tumor suppressor gene inactivation leads to cancer growth because it's normally suppressing the tumors at baseline, versus an oncogene, we're saying that activation is what causes the tumor to grow. So an important thing to keep in mind, and it relates back to kind of our biochemistry and our basic science. Now, when we talk about the presentation here, remember I said this is classically going to present in childhood, specifically early childhood, around a 2 to 4 year range. So if we have a question stem and it's asking about a 72-year-old patient or a 57-year-old patient, we're less likely to be thinking about a Wilms tumor or nephroblastoma. We're more likely to be thinking about what pathology? That's right, a renal cell carcinoma, because we know a renal cell carcinoma is a malignant tumor we would typically expect to see in an older population, versus a nephroblastoma we typically expect to see in a much younger population. Additionally, some other important presenting findings I want you to keep in mind include a large, palpable unilateral flank mass with or without, so plus or minus, abdominal pain. So if these tumors develop, they can get very large over time, that they can cause pain for a patient. However, if they're smaller and they're not causing pain, that doesn't have to be a present symptom for this diagnosis to be there. Now, super high yield, I want to keep in mind, this typically does not cross the midline. So we're saying it's a unilateral mass that does not cross the midline. And why am I highlighting that so much? The reason I'm highlighting that so much is because there is a similar, albeit different pathology called a neuroblastoma, in which does cross the midline. So sometimes they'll give you a patient that presents with very similar symptoms. They have some kind of abdominal mass you can attribute to the renal system, and then it's really going to give you the physical exam and expect you to know the difference between, oh, I was able to palpate the mass on the left side or the left flank, versus, hey, this mass was really, really large that I could actually palpate it on the left and the right side. That's going to change what we're thinking in our differential diagnosis. And so because sometimes that'll be the only clue, the only distinguishing factor between these two, I put the high yield button so that you remember this on test day. Now, moving on to some other classic symptoms we expect to see. So this is going to be hematuria and hypertension as well. Now, keep in mind with a lot of these physical exam findings, they're not present in all patients, right? They're clues that we're dealing with the renal involvement. However, the hematuria, the hypertension might only be present in about a quarter of the patients. The abdominal pain might be present in less than half of them. So you really have to use all of your clinical clues, the patient's history, your physical exam, and your labs to make the diagnosis. There's not really a classic presentation where they're always going to present it in one patient, but the main thing that they will do to distinguish it is going to be this clue of telling you it doesn't cross the midline. That's why I want you to keep that in mind. Every other presentation is essentially things that we could just expect to see with renal involvement. They don't have to be there, but they could be there, indicating we are dealing with a renal pathology. Now, moving on to our diagnostics, we're going to use kind of the classic ones we use for kidneys. We're kind of having a theme at this point. We're often getting a urinalysis, we're often getting some imaging, and the same thing holds true here. So you're likely going to see the hematuria on a urinalysis. Again, this is not super specific for what type of pathology we're dealing with, but it often does indicate that we're dealing with something that is in the genitourinary system or the urinary tract itself. Then we can also get the imaging study, which is most likely to be an ultrasound. Why? Because this is fast, this is a cheap study relative, and this is not very invasive for a patient, right? Typically in children, we don't want to expose them to radiation. And so while a CT could be considered, this is going to expose them to radiation that they might not otherwise need. Additionally, a more expensive and time-consuming test that could be used for staging and surgical planning is an MRI. So the first test to do would be to get the ultrasound, see the scope. If this is something that needs to ultimately be removed, and we'll talk about that in our management section, then doing further planning with a CT or MRI could be warranted at that time. Now, also something I didn't include here because we don't typically get it, you could get a renal biopsy. It's not often done. Typically, we can make this diagnosis without it. But if you are getting a renal biopsy, you might see the metanephric blastomal cells that we talked about, which is a combination of stromal cells and epithelial cells as well. Sometimes they will refer to the histologic findings as a triphasic nephroblastoma, which includes three things. It's going to be your epithelial cells, your blastomal cells, and your stromal cells. Now, when we move on to our management options here, we're going to be dealing with a couple of different things. So if this is a large compressing tumor, right, we're going to do a nephrectomy. We're going to remove it, plus or minus chemo and radiation. Sometimes if this tumor is removed early and it hasn't actually metastasized to other places in the body, we might not need additional treatment. If you catch it and it's local, you remove the tumor, you may not need chemo and radiation as well, and that's why it's a plus or minus depending on the patient's presentation and condition. Now, we also want to consider that this patient is likely to have a good prognosis, right? Greater than a 90% survival rate. And this is really good to know because when you're counseling patients and parents, right, it's important to give them a realistic view of how severe this is going forward. This is a very scary thing to hear that your child has, but it's important to give them the data. And the data suggests that 9 out of 10 people have a really good prognosis and will survive with the appropriate treatment modalities. And finally, to wrap up this video, I want to focus on a couple associated syndromes. So there's one called Beckwith-Wiedemann syndrome, one called Denise-Drash syndrome, and one called WAGR complex. So these are syndromes that are associated with having a Wilms tumor. So a patient who has a Wilms tumor but has additional findings, such as in Beckwith-Wiedemann, they would have things like macrosomia, macroglossia or an enlarged tongue, hemihyperplasia, or organomegaly. And this constellation of findings is what we define as Beckwith-Wiedemann. Also, for the purposes of step 1, they like you to know the specific gene involved. And so with this condition, we're dealing with a WT2 mutation. Remember earlier in the video, I said we have a couple different WTs, WT1 and WT2 that can be involved. In this specific one, it is a WT2 mutation. Now, looking at Denise-Drash syndrome, we have something called pseudohermaphrodism, which is a mismatch between a patient's gonads and their actual secondary sexual characteristics. So a patient could have male gonads and then female secondary sexual characteristics, or the opposite. They could have female gonads with male secondary sexual characteristics. Patients with this condition can also have early onset nephrotic syndrome, and this is due to a WT1 mutation. And finally, we have WAGR complex, which has the Wilms tumor. This is a memory aid to remember the first letter WAGR for each of the associated symptoms. This also has aniridia. Aniridia is the abnormal development of the iris around the eye. So that is what the A stands for. The G stands for genitourinary malformations. And notice I kind of put below that the GU anomalies that we're talking about with this condition include pseudohermaphrodism and early onset nephrotic syndrome. So you're probably wondering, how do I keep that straight from Denise-Drash syndrome? Because these are also present there. And the idea is that if they only give you those two symptoms, I want you to think of Denise-Drash syndrome. If they give you additional symptoms, such as the eye abnormalities, right, the aniridia, or the last one, which is the range of developmental delays, then I want you to be thinking about WAGR complex. And finally, for the sake of knowing the chromosomes, we have a WT1 deletion here. So a classic vignette is going to be something along the lines of a 2-year-old comes to the pediatrician with their parent. The parent noticed a large abdominal mass in the patient and they wanted to get it checked out. Overall, the child is asymptomatic. However, they've been a little bit more fussy lately, crying a little bit. On vital signs, you notice that the patient has elevated blood pressure, which can be due to the fact that they have hypertension because these tumors are known to secrete renin. We know that renin can then activate the RAS system, leading to hypertension in a young patient. Now, on physical exam, you feel for a mass. You feel it as well. You notice that it does not cross the midline, and you confirm this by getting an ultrasound imaging to see that this indeed does not cross the midline. The most likely thing that this patient has at this point, given their age, given their presenting symptoms, and their ultrasound finding, is that of a Wilms tumor or a nephroblastoma. Just a quick review of this video highlighting the main points here. So nephroblastoma or Wilms tumor made of metanephric blastomal cells. Etiology is often unknown. However, there are some genetic conditions, some genetic associations, which we talked about here in the associated syndromes. We have a few different ones. Presentation here is going to be in a child, right? We're not typically going to see this in a really old individual, at least for test-taking purposes. We're also likely to see some other renal findings, including hematuria or hypertension, although not always. Our diagnostics are going to include our standard urinalysis and imaging. We're going to start with an ultrasound, but if surgical intervention is indicated, then we would consider doing additional imaging such as an MRI or a CT scan. Overall, really good prognosis for this condition if it's treated appropriately in the patient, and so this is important for counseling the parents as well. And finally, with the associated syndromes, I want you to keep in mind there are a few of them that can include both a Wilms tumor and a variety of other different syndromes. So if a patient has a Wilms tumor plus one of these constellations of findings, that's going to change kind of the name of the diagnosis more or less.